Good afternoon. I am James Satriano. I am from Columbia University HIV Mental Health Training Project of the Northeastern Caribbean AIDS Education and Training Center. I'm here to talk to you today about HIV and mental health. May I have the first slide, please?
One second.
Okay, and you can go on to people living with HIV and AIDS. The first slide I want to talk to you about, these are the rates of selected psychiatric disorders among populations of people living with AIDS compared to the general population in the United States. And you can see certain disorders are highlighted and much higher among people living with HIV and AIDS than they are in the general population. While lifetime alcohol use disorder is a little lower, current drug use disorder is much higher. Lifetime drug use disorder is much higher. Current rates of depression and post-traumatic stress disorder are much higher in people living with HIV and AIDS. So those are some of the mental health disorders that we see. Next slide, please. So why is the burden of mental health so much greater in HIV? Well, several factors impact on HIV and mental disorders and make their incidence higher. Demographic information is relevant in both of these things. You see younger population with HIV and diagnosed with mental disorders. In terms of gender for HIV, it has primarily been among the male population in the United States, simply because of how it entered the infection entered the country with gay men and intravenous drug users in this country. And it's not that women don't use drugs, but for people who inject drugs, they tend to be male. That covers sexual orientation to gay men. Biological factors of chronic immune activation and autoimmune disorders, of course, are common with HIV. And we see autoimmune functions related to mental disorders too, which I'll get into later. In terms of community, HIV tends to be higher in communities of high density. In psychosocial, loss and bereavement, psychosocial supports, socioeconomic status, HIV tends to be higher among poor, less educated people. People with housing problems and housing insecurities have higher rates of HIV. And all of these things can intersect in stigmas, and we have intersecting stigmas with both mental illness and HIV infection. And when you have both, it's sort of a double whammy. Next slide, please. Now, the behavioral pathways between mental health impairment and HIV is clear. Could you hit the button, please? HIV infection. Mental illness increased risk behaviors for HIV, which I'm going to get into in future slides. Again, please. If you have mental health needs and HIV, you get a delayed treatment or a lack of testing and treatment. People who are mentally ill tend not to be tested for HIV or tend to delay the treatment once they are tested for HIV and test positive. Next, please. Poor retention and care, especially with depression. People tend to not come in for care or not come in for follow-up appointments. Next slide, please. That's also true for medications, antiretroviral therapy. There's a lack of or delayed initiation or failure to adhere to medications once it is prescribed. Last, please. And poor ART adherence, antiretroviral therapy adherence. People who have mental health needs tend not to take their medication as dispensed, which can lead to the medication being ineffective against the virus. Next slide. I've covered all this stuff. You can go to the next slide. So what is the focus of trying to highlight mental health in terms of HIV prevention and care? Well, this 90 and 90 and 90 percentage things are goals. And these are goals we set up in New York State. The governor set up an End the Epidemic initiative several years ago, and you have the same thing in New Jersey. So we're trying to get 90% of our HIV-infected population diagnosed, 90% of those who are diagnosed into treatment, and 90% of people in treatment virally suppressed. So those are the goals for the 90, 90, and 90. Let's see how we're doing. Next slide, please. This is the latest data that's available for New York State. And as you can see, we in 2016, which is the latest data that was available at the time of this presentation, we had 121,000 people estimated to be living with HIV in the state. And of that, 93% were diagnosed. And that's pretty good. That's over the 90% of the goal that was set for individuals diagnosed. But how are we doing with getting them into care? Not quite as well. 74% of persons, the estimated population of persons living with AIDS were in care, and 80% of those who were diagnosed were in care. So still shy of the 90%. And in terms of viral suppression, even less than that. 65% of the total population virally suppressed, 70% of persons living with AIDS who are diagnosed, but 87% in any care at all. Now, I went back and looked at the data for New Jersey too, and we found that, and I saw that in a Rutgers report, that your cases are less in New Jersey, about 37,000 estimated to be persons living with HIV in the state, with 1,000 new cases every year. And that 52% of your diagnosed population is virally suppressed. So you got some work to do there. Governor Murphy has initiated an End the Epidemic initiative by 2025. And so you still have some work to do there. The estimates that in New Jersey that there are still about approximately 5,000 undiagnosed cases of HIV infection. So more testing is necessary to find these individuals. Next slide, please. Let's look at where mental health and HIV stand on the global burden of disease. And this is a ranking of numbered years living with disability. And mental illnesses and substance abuse are #1. So if you're diagnosed, you can click the slide, please. You can click it twice. That's it. If you have a mental health and substance use disorder, they're of course lifelong disorders and need to deal with them. HIV is down at 15 in terms of lifelong years lived with a disability. So these are things that are very high, and to have them together is, again, doubly discriminating and doubly difficult to deal with and to get care for. Next slide, please. So there's a wide range of behavioral health problems that are found in people with HIV and AIDS, mental health problems, psychotic illnesses, which I'm going to talk about, neuropsychiatric disorders, and these are either due to opportunistic infections and diseases because of immune dysfunction, or HIV itself. HIV is neurotropic. It enters the central nervous system early after diagnosis, and can affect the brain in terms of AIDS-related dementias. But I'm not going to speak about those today. Depression, I'm going to talk about at some length later in the presentation. Anxiety disorders, I'm not going to speak about today, but I do want to mention that anxiety disorders are elevated among the HIV population and mostly tied toward markers of disease progression. So when you're first diagnosed as HIV positive, there's high levels of anxiety. Any change in your health status, there are high levels of anxiety. Any drug failure or change in medication as a result of drug failure, there are higher levels of anxiety. Alcohol and substance use disorders are common, as you saw in an earlier slide, among people with HIV. And substance abuse can either be a direct cause of HIV infection if you're sharing injection equipment. That doesn't happen all that much anymore, and we've quite radically lessened the extent of that. But the disinhibitory properties of substance use and alcohol use can put people at risk for higher risk sexual behavior. So that tends to be common among this population. Stressors, including post-traumatic stress disorder. A lot of people who are HIV infected in our current age come from lives of trauma. So it's not uncommon to see high rates of post-traumatic stress disorder. Some of them live continuous lives of traumas. Sex workers, people who are injected to opiates, just doing what they have to do every day to meet their needs in terms of opioid addiction or ongoing sex work can be traumatic. So we see high rates of post-traumatic stress disorder and personality disorders, which I'm going to talk about later in the presentation. Next slide, please. So I'm going to talk about HIV infection among people with serious mental illness. And when I talk about serious mental illness, I usually mean people with schizophrenia, schizoaffective disorders, psychotic disorders. So next slide, please. So mental illness is a risk factor for HIV acquisition, and mental illness contributes a 4 to 10 times increased risk for acquiring HIV. Current studies looking at the population of people with serious mental illness show infection rates of 2 to 6% among this population. And compare that to the general seroprevalence rate of HIV in the United States of about half of 1%. You can see it's greatly elevated. So mood disorders and alcohol and substance use disorders, they contribute to even higher risk, and I'm going to get to those later. Next slide, please. So people with serious and persistent mental illness, and these are the individuals I was talking about, schizophrenia, schizoaffective disorder, and the psychotic disorders. This was a summary of a group of studies that were done mostly in New York State hospitals looking at population of people with serious mental illnesses. And interesting, I'm going to start at the bottom and work my way up in this slide. The dual diagnosis patients, these are people who are admitted to a psychiatric hospital who had a concurrent substance abuse disorder. And the rates of infection were very high among this population, 16.3% infected to 22.9% infected, really high among the population. For admits to general psychiatric wards that did not have a substance abuse disorder. Now these data are old. These are about 20. These data are over 20 years old. So the current data are a little less now, 5.2 to 8.9%. And even among long-stay chronic inpatients, the rate was 4%, which is 8 times higher than the general population estimates. And this was quite surprising because these were people who had been in the hospital for at least a year and had been so psychotic they couldn't be discharged to the community. So these were among the most sick of the mentally ill patients, and still had an 8 times infection rate compared to the general population. Next slide, please. So what are the risks for this population? Like everybody else, substance use can be a risk, and these individuals tend to have high rates of substance use disorders, tend not to be injection drug users, but will inject drugs if they're hanging out with other people who inject drugs. So they don't look like what generally you would think of as someone who's injecting heroin every day, but they would tend to perform that behavior if they were influenced by others around them. In terms of sex, people with very high rates of or high degrees of mental illness, like I said, psychotic illnesses, tend not to have long-term stable partners, but we see high rates of sexual victimization among this population, and something that we don't call prostitution, but sex exchange, where individuals were exchanging sex for a safe place to sleep at night, something to eat, or drugs or alcohol. So they were exchanging sex for these things and put them at risk for HIV infection. Next slide, please. So what are the challenges in dealing with this population? These people who are very disabled psychiatrically, their behavior is disruptive in healthcare settings. For people who deal with an HIV population, they may not be trained to deal with a population that has high degree of psychiatric needs. So you can see agitation, intoxication, drug-seeking behavior, non-adherence to HIV care and treatment, or an inability to understand the complicated treatments. And they have complex needs and poor outcomes and poor quality of life, despite reasonable adherence to HIV treatments. And we see some immune function dysfunction among people with certain mental illnesses that are independent of HIV infection. So that impacts on HIV, the course of HIV and HIV treatment. Next slide, please. So first I want to talk about depression and HIV. Next slide. So the behavioral health problems most strongly associated with poor outcomes for HIV are depression and hazardous substance use, and that includes alcohol use. So if you're an alcoholic or have problematic substance use disorder or major depression, these things are likely to occur. There's an increased morbidity and mortality associated with both of these disorders, substance use disorder and depression, when having a concurrent HIV infection. There's a failure to initiate antiretroviral treatment. People who are depressed don't go into treatment. People who are substance abusing don't seek treatment out. There's a failure to adhere to antiretroviral treatment once initiated. There's slower virologic suppression in depression and faster virologic failure in substance use. We're not sure exactly why that is, but the depression seems to have a psychoimmunological function itself, and the faster virologic failure in substance use is probably due to non-adherence to medication. And we also have increased HIV risk behavior, certainly among people with substance use disorders. So, and can transmit the virus to others, especially if they're not adhering to antiretroviral treatment and they're not suppressed to a level where their virus cannot be passed to others during high-risk sexual behavior. Next slide, please. So major depression and substance use. A third of patients with major depressive disorders have a concurrent substance use disorder. So these things go hand in hand. People who tend to be depressed tend to abuse substances. Patients who have both of these things are more likely to be male, younger, divorced or never married, have a history of family history of substance use disorder, and have a higher suicide rate. And if you note, patients who are depressed and have a substance use disorder, these patients more likely to be, those are also a pretty good snapshot of those at risk for HIV infection. Male, younger, never married, have a history of substance use disorder. So again, that's why they co-occur so readily. Next slide, please. So if you have one of these disorders, depressive symptoms, heavy alcohol use, stimulant use, polydrug use, or childhood sexual abuse, you are at risk of HIV infection. If you have more than one of those conditions, you're at greater risk. And the more of these conditions you have, the more likely you are to become HIV infected. If you look at this graph on this slide, the top solid line is 0 risks, and you can see that there's not, as the curve decreases more sharply, it's more risk of HIV infection from over time. So the steeper the curve, the greater the risk, and you can see 4+ conditions has the greatest risk, and as each condition is added to the risk profile, you can see the risk increases. So the probability of staying HIV negative goes down as the number of these conditions in an individual goes up. Next slide, please. Depression is one of the most frequent comorbidities of HIV infection. If you look at the literature, and it's pretty wide-ranging over HIV, reported rates of depression among the HIV population range from 0, one study found nobody was depressed who had HIV infection in their sample, to as high as 80%. Well, we found generally the finding now is that 30 to 50% of people in HIV care, there's depression present for people who are getting treatment in treatment settings. So the middle numbers are usually about right, about 30 to 50% of people receiving care have depression. So next slide, please. Depression is best conceptualized as a medical comorbidity of HIV infection. They go hand in hand a lot of the times. And major depression is as much a physical illness as it is a mental illness. The mental side of it, the depressed mood, the anhedonia, or loss of interest in things, feelings of guilt or worthlessness, that feeling of hopelessness and not being able to look forward to anything in life, and having suicidal ideation or feeling that you're better off dead or people around you would be better off if you weren't around anymore. Those are the psychological components or the mental components of depression. But depression also has physical attributes that include appetite change and weight loss. Even though people report that they eat the same as they used to, they also show rapid and sustained weight loss. Sleep disturbance, either sleeping too much or not being able to sleep. Psychomotor agitation or retardation, people reporting being fidgety or moving so slowly that others noticed it. Feelings of fatigue, like they're just so tired all the time, they don't have interest or energy to do anything. And lack of concentration. People report that they used to enjoy reading or watching certain television shows, but now if they read a paragraph, they can't remember at the end of the paragraph what the beginning was about. Or halfway through a television show, they realize they've been looking at it, but they don't even know what the story's about. So those are the physical aspects of major depressive disorder. Next slide, please. So depression may negatively impact the immune system directly. There is evidence emerging of a bidirectional relationship between depression and inflammation. And inflammation is in the body is a marker of injury or disease. Depressed people with a major depressive sample had a 46% higher rate of C-reactive protein, which is a marker of inflammatory disease. There is definitely increased morbidity and mortality associated with HIV among persons living with HIV and AIDS. And this was found prior to the availability of antiretroviral therapy. So people who were depressed were dying faster. So, and we also don't have studies who examine directly whether if we treat depression among the HIV population, people would live longer. But we do have that evidence in another area. We know with patients with cardiac disease, that if they have cardiac disease and major depression, and depression is treated effectively, their lifespan increases. So we have reason to believe that effectively treating depression among people living with HIV would increase their lifespan as well. Next slide, please. So I told you depression and is related to HIV-related mortality, and I want to talk to you about a couple of studies. This was a study, a cohort of 765 HIV-positive women in the United States, and they were followed up for 7 years. And the mortality predictors were chronic depression, these were HIV-positive women, CD4 cell count, antiretroviral treatment duration, and age. After adjusting for CD4 cell count, antiretroviral treatment duration, and age, it was found that women with chronic depressive symptoms were twice as likely to die than women with limited or no depressive symptoms. I'm going to repeat that again because this is a significant finding. Women with depressive symptoms, when controlling for everything else, were twice as likely to die as women with limited or no depressive symptoms. Next slide, please. Here's another study that was done in Africa. This was almost 1,000, again, women, HIV-positive pregnant women in Tanzania, and they were followed for 6 to 8 years, and this was before antiretroviral treatment was available there, and they were given vitamin supplementation. Most of the women were in World Health Organization clinical stage 1 of HIV, and stage 2 had 17%. 31% of the samples died during follow-up. And depression in this population was associated with a 60% increase in progressing from stage 3 to clinical stage 3 to 4 of HIV disease, and a greater than twofold increase in risk of death. Again, here's a doubling of risk of death if you have HIV and depression without treating the depression. Next slide, please. And the longer depression goes on, the worse HIV outcome is. There's a dose-response relationship between depression length and HIV outcome. This was a study of almost 6,000 individuals living in with HIV. And for each 25% increase in days with depression, there's a 19% increase in mortality from HIV. And you can see the mortality rate in the chart on your right. So as the days spent being depressed go up, the mortality goes up as well. Next slide, please. So what do we do about this? How do we tell if someone's depressed? How about if you ask 2 questions? Over the last 2 weeks, how often have you been bothered by the following problems? Little or interest or pleasure in doing things, and it's scored on a 0 to 3 Likert scale, or feeling down, depressed, or hopeless. Again, not at all to nearly every day. If you get a score of 3 or more, major depression is likely. And I want you to do something further if you get a score of 3 or more. Next slide, please. ask 7 more questions. You've already asked the first 2. So starting on number 3, are you having trouble falling asleep or staying asleep or sleeping too much? Feeling tired or having little energy? Having poor appetite or overeating? Feeling bad about yourself, that you're a failure or you've let yourself or your family down? Having trouble concentrating on things such as reading the newspaper or watching television? Moving or speaking so slowly that others have noticed? Or the opposite, being so fidgety and restless that you've been moving around a lot more than usual? Or thoughts that you'd be better off dead or hurting yourself in some way? Again, these are all scored the same way on that 0 to 3-point scale. And you can see from what I just read that these things correspond to both the psychological and physical manifestations of major depressive disorder, as I discussed earlier in this presentation. So this is how to screen for depression. Next slide, please. So what do we do if we find someone's depressed? Well, we have effective psychotherapies for depression. Cognitive behavior therapy, which concentrates on the thought process itself and negative cognitions and what people tell themselves about themselves and remedying that. Relatively short-term therapy. We have interpersonal psychotherapy, which concentrates on their interpersonal relationships, combats isolation, tries to get them to engage more with others. These are available as sole treatments to mild and moderate depression, and they tend to do well. And for people who are more depressed, in combination with antidepressant medication, they tend to work well. The problem is these therapies are often not available in settings where HIV care takes place because the providers aren't trained to do it, they're not reimbursed for it, or there's a poor dissemination of how effective it is, or it's just not a priority in an HIV care setting. And given the fact that depression can double mortality, this should be one of the priorities in an HIV care setting, both evaluating for depression and treating it. Next slide, please. Depression and art adherence. The connection is very clear. Next, please. So here are 2 studies that looked at antiretroviral adherence to medication and major depressive disorders. And depression was significantly in both of the studies associated with non-adherence. You can look up the studies if you want to read them and see the data yourself, but I'll just mention the second study. There was a 42% lower, adherence was 42% lower among those with depressive symptoms as those without. So treating depression can increase adherence. You need to adhere to antiretroviral medications to get down to non-detectable viral loads where you would be uninfectious to others and live a long and healthy life. Next slide, please. Beyond depression, you know, in the context of the comorbidities and vulnerabilities of the unstable housing, food insecurity, domestic violence, trauma, stigma, discrimination, people with living with AIDS are likely to have other psychiatric problems as well, including personality disorders. Click it again, please. Anxiety disorders, which we already talked about as being tied with markers of disease progression. Next slide, please. The next click. Alcohol and substance use disorders, which I mentioned. Next. Post-traumatic stress disorders that I also mentioned. And next. Next slide, please. But what I want to talk to you about is the personality disorders, since I haven't addressed those yet. And there are 10 different personality disorders listed in the Diagnostic and Statistical Manual of Mental Disorders, most of which you're unlikely to see in HIV care settings, but 2 of which are likely to be overrepresented in HIV care settings. Next slide, please. And those are borderline personality disorder and antisocial personality disorder. While it is not universally true that borderline personality disorder occurs among women, you are much more likely to be female than male if you carry that diagnosis. This opposite is true of antisocial personality disorder. You are much more likely to be male than female if you carry that diagnosis. Certain people think that they're gender-specific expressions of the same underlying psychiatric disorder, but yeah, that may or may not be the case. But being that as it are, where there are female antisocials and male with borderline personality disorders. So I'm going to talk a little bit about these because these can be some of the most disruptive people that come into an HIV clinic and most difficult to deal with. Next slide, please. So the differential diagnosis of antisocial personality disorder and borderline personality disorder is unlike other mental disorders. People with other mental disorders usually come in complaining about a symptom. Someone with depression can tell you, if, you know, when I ask them about it, they can tell you they've lost their will to live, that they might be better off dead, that they're having suicidal thoughts, that they don't look forward to the future. Even people with severe mental illnesses will report that, yes, they do hear voices that other people can't hear, and they're being, you know, told things that other maybe have beliefs and things that other people don't know about. So they will admit that you know, there's something wrong, and they can recognize that they experience reality differently than people who don't have a mental illness. Well, people with personality disorders, especially antisocial and borderline personality disorder, their behavior is egocentric with their illness. They think that there's nothing wrong with them, that their problems are with other people. It's the other people who have the problems, that they're not doing anything wrong. So that leads to a problem with a failure for them to recognize what they're bringing to the situation. So next slide, please. So both borderline and antisocial personality disorder involve a self-dysregulation, a problem relating with how they relate to themselves, interpersonal dysregulation, problems with how they interact with other people, behavioral dysregulations, which is why other people and what other people notice about these individuals and why it's why these diagnoses are usually made. Remember, if these individuals don't report there's anything wrong with them, that the problem are with other people, they're unlikely to complain about it. It's others that complain about these individuals. And there's a cognitive dysregulation. They think about things differently than others, and I'm going to go into that a little further into this presentation. Next slide, please. So for borderline personality disorder, the self-dysregulation is a profound identity disturbance. There's a very profound unstable self-image and leading to chronic feelings of emptiness and loneliness. This manifests itself in an interpersonal dysregulation, where they feel like they're about to be abandoned by anyone who is in their lives. So there's frantic efforts to avoid these real or imagined abandonments. So if you're dealing with someone with a borderline personality disorder clinically and you need to go on vacation, they're going to act up. They see it as an abandonment. Or if their care has to be taken over by someone else, they're going to tend to act up. It's going to be a problem for the staff. And this is further manifested in something that they do interpersonally, and it's called splitting. There's an unstable and intense way that they deal with individuals that will over-idealize or devalue them. So someone is seen as either all bad or all good, and that can occur within one person. They see you as, you know, you're the best person that's ever dealt with me on this, you're the most helpful. If you tell them that you can't do something for them, you're worthless, and they're screaming at you. It can happen between individuals. I was once asked by a mental health worker, she said, we have a patient at our clinic who's diagnosed with borderline personality disorder. And she came up to me last week and said that you know, she sees how I am with my patients, and that the therapist she's seeing is not working for her, and that she thinks I'm so effective at what I do, and I'm so good at what I do, and would I mind if she switched to my caseload? And I said, well, you certainly can take her onto your caseload, but you have to realize that next month you're likely to be that for that individual that's not meeting her needs and in some way not able to come up to her expectations. So the over-idealization is going to lead to devaluation at some point. Next slide, please. The behavioral dysregulation, and this is what puts these individuals at risk, is destructive impulsivity, and it can happen in many different areas: substance using, reckless driving, binge eating, spending, and sexual activity. We see a lot of sexual acting out in patients with borderline personality disorder, which of course, with a lot of different sexual partners, puts them at increased risk for HIV infection. These relationships that they have are often intense and inappropriate, with anger and agitation. I was once seeing an individual patient with borderline personality disorder. She came into session one day and told me she had met the man of her dreams, that they were really hot for one another. They couldn't keep their hands off of one another. They were just a perfect match. They shared a lot of things in common. I saw her the following week, and she reported that he had called the police, and she had been taken from his apartment in handcuffs, and he had sworn out an order of protection against her. So you can see the anger and inappropriate anger and agitation. I don't know what went on beyond her side of the story, but that's rather typical in a way to end a relationship for someone with borderline personality disorder. Something I want to mention with these individuals is there were recurrent suicidal gestures, threats, or suicidal behavior. We can frequently see patients with borderline personality disorder with a lot of self-cutting. And this is an interesting, if you get a couple of these individuals together, they'll share a cutting tool. If one of them is HIV positive, there's a risk of spreading infection to the other through the use of a cutting tool like that. So that's a unique HIV risk among this population. But one of the things I want to say is you get a lot of suicidal gestures and threats from these individuals, but they need to be taken seriously, because a full quarter of these individuals will go on to make a serious suicide attempt. So it's best not to completely discount their threats of self-harm. And finally, there's a cognitive dysregulation among these individuals, and it can be transient states of paranoid ideation or severe dissociative symptoms, where these individuals report that they don't feel that they're in their own bodies or embodied in some way. Just as an illustrative examples, we've had patients with borderline personality disorders tell us they cut themselves to see if they can feel it. That's that severe dissociative. And sometimes the dissociation does require hospitalization. So be mindful of that, and be sure to evaluate that if you're suspecting someone is having severe paranoid ideation or dissociative symptoms. Next slide, please. Antisocial personality disorders, again, you're seeing a self-dysregulation. There's a disregard for danger to themselves or others. They lack empathy. They don't really care if there's harms come to themselves or others. Thus, if they're HIV infected, they don't care if they infect others. Someone gave it to them. They have a very profound inflated self-esteem and a grandiose kind of attitude. So this leads, of course, to interpersonal dysregulation. They're lying and deceitful. They're manipulative, and they manipulate with charm a lot of the times rather than intimidation. They've found that if they can charm people out of something, it's much easier for them to get something than intimidating people. They may tell you, oh, that shirt you have on looks great on you. The color, just brings out the color of your eyes. But they don't give a damn about your shirt. They want something from you. And they're just as likely, if you refuse to give it to them, to threaten you. So, but they will manipulate you in this way. They lack empathy or caring about others. So again, that puts them at risk of infecting others. They tend to have a lot of different sexual relationships. So they tend not to stick with one person sexually, but be in sexual relationships with a lot of people at one time. They're also jealous. They don't want those that they're in relationships with talking to anyone else. So they can lead to the behavioral dysregulation with the agitation and aggression, the destructive, self-destructive impulsivity, and high rates of substance abuse among this population. So next slide, please. So how do you deal with these patients? Well, First of all, I want to say that it's very difficult clinically to deal with patients with antisocial personality disorder. If any of you remember watching The Sopranos, Tony Soprano was supposed to have antisocial personality disorder, and at the end of the show, his psychiatrist throws him out of treatment because she comes to the conclusion that he's only in treatment to justify his ongoing actions, not to improve in any way. And a lot of times that's the attitude that you can get from people with antisocial personality disorder. Frequently, the only reason they're in psychological treatment to begin with is because they've been court ordered to. So, borderlines will come into, people with borderline personality disorder will come into treatment. But if you're going to treat these individuals, 4 pillars of treatment are necessary. Effectively communicating with them. People with borderline personality disorders are difficult to deal with. People tend to walk away from them or run away from them. Face them, look them in the eye, deal with them directly. Use an integrated team approach. Have a lot of people involved in the treatment of the individual, not just one person, or they get tired of treating the individual. Use an effective treatment plan, and I would include a behavioral contract with that. After a while of dealing with individuals with these personality disorders, you will understand a pattern of things that they do that are disruptive both to themselves and your program. Get them in, make a verbal and written agreement and have them sign it. And I guarantee you they'll break it, but at least you can bring them in and say, look, a lot of these individuals react to things in the immediate presence. They don't take lessons from their past, apply it to the present situation to keep bad things from happening to them in the future. And you can do that with a behavioral contract. You can say, look, we agreed to this. Here's what's happening now. We need to get back to that. And you have to do it consistently. You have to do it over time. It's kind of like trying to change behavior in a disruptive child. But if you do something consistently over time, behavior can change. So next slide, please. I want to talk about screening and treatment for these mental disorders I've told you are so prevalent in the HIV population. Next slide, please. And you can keep clicking this. Click this a bunch of times, please. So these are general screening. One more time, I think. Or that's it. Nope, go back. Oh, just click it again. Thank you. These are all screenings that are available online or for free, and you can find them quite easily by typing them into Google. They're easy to administer. They're easy to score. So you can screen for mental health disorders quite easily. It doesn't take a postgraduate education to do it. But, you can find out who's got these issues pretty reliably and pretty consistently. Next slide, please. Go ahead and keep clicking. And so once we screen, what do we do? Whether psychopharmacological treatment or medication treatments that are effective for depression, for psychosis, for certain anxiety disorders, although I caution against using benzodiazepines too much in this population. Next slide, please. And there are psychotherapies, psychodynamic, which is tends to be Freudian-centered therapy or Freudian-like therapy, cognitive behavior and motivational interviewing and interpersonal therapies, which tend to be time-limited and goal-directed therapies, quite effective, especially for depression and anxiety disorders. Keep clicking. Stress reduction and mindfulness interventions, which are becoming more and more popular. Harm reduction and abstinence treatments, and one more time, I think. And a lot of these things are manualized and can be taught to administer in HIV settings and being scaled up for an HIV settings. And technology is becoming a greater part of this too, where individuals don't have to go in for treatment, but can get treatment online over the internet. So next, please. So what are the practical tips for integrating mental health treatment into HIV care? Well, we don't know, if we don't screen patients for mental health needs, we can't identify those who have mental health problems or the plan to intervene. Use a team approach. No one healthcare provider should be the designated person that needs to deal with all the borderline patients or all the depressed people. Get everyone up to speed on how to deal with these individuals. Try to keep care affordable. Healthcare providers need to work at the top of their licenses. If you're seeing patients with multiple needs, you need to develop multiple skills. Include patient self-management. This is not just about you changing them. This is about them taking responsibility for changing themselves also. And as we move away from fee-for-service reimbursement, we need a more flexible teamwork approach to providing care for this population. Next slide, please. So we have valid mental health screening tools, an array of effective mental health treatments. How are we doing with diagnosing mental health conditions and treating them? Next slide, please. This is a snapshot of treating childhood depression in a study that was in a pediatric journal. Well, you can see of all the prevalent cases of children with depression, the first bar of 100%, only 47% were recognized clinically. And for those, 24% of the total cases got treatment. 9% got adequate treatment. And only 6% of those prevalent cases of depression among children achieved remission. That's a pretty abysmal statistic. Next slide, please. No, I already talked about that. Reality of the mental health treatment gap. The majority of people, 70 to 85% of people in the United States, this is across all country settings that were studied, did not, for people with mental health need, did not receive care. Of course, there's a human resource shortage, fragmented service delivery models, a lack of capacity to implement and policy changes, but it's not seen as a priority right now to provide mental health treatment. I think that is changing as people within the medical community see that they're having more and more trouble providing medical treatment to people with mental illnesses. Also, mental illness is stigmatizing, so to identify someone who has a mental health need and get them into care starts with the patient. A lot of times people say, I don't want to go see the psychiatrist or psychologist or social worker. Are you telling me I'm crazy? I'm not crazy. But that goes on to healthcare workers too. Healthcare workers stigmatize people with mental illness and policymakers too. Mental health care seems to be the last kind of care that receives support for treatment. Next slide, please. So what can we do in HIV? Well, maybe we can lead the way for those in HIV field of integrating mental health into ongoing care. Next slide, please. Opportunities for mental health intervention can occur at any point during HIV-related care. Click it, please. When accessing STI testing and treatment or being evaluated for PrEP. If people are out getting PrEP, we can evaluate them for mental health needs then, or when they first come in for HIV testing. Next, please. If they're HIV infected and they're diagnosed and they get into treatment, this is another time where we can screen for mental health needs. Next slide, please. Once they're linked to care, there's another opportunity to assess and treat mental health needs. Keep going. Retained in treatment and being prescribed medication and getting to undetectable viral load, all times to evaluate person's mental health status and intervene with treatment if necessary. So there's a lot of opportunities and a lot of clinical care goes on in delivering HIV-related services. And there are a lot of opportunities to screen for mental health needs and deliver care. Next slide, please. So if we deliver mental health care, is it effective? This is a meta-analysis of 181 studies, and it was done internationally across low, middle, and high-income countries, and it represents over 20,000 subjects in the different studies representing all populations. Some of them were randomly controlled studies, and some of them were pilot studies and feasibility studies, and some quasi-experimental designs. And they ranged in duration from hours to months of follow-up. And some of them were psychopharmacological interventions, which are the administration of psychotropic medication. Some of them were symptom-oriented, were cognitive behavior therapy or stress management, interpersonal therapy or motivational interviewing. Some of them were supportive interventions with support groups or psychoeducational groups. And some of them were meditation interventions with relaxation and mindfulness treatments. So what did they find? Next slide, please. The key takeaways was that there was a small to moderate positive effect of mental health treatments, especially in reducing depression, reducing anxiety, improving quality of life and psychological well-being. And as you do all those things, you'll improve adherence to treatment, to HIV treatment, and thus prolonging life. The biggest effects, of course, were in the lengthier treatments. The more treatment you got, the better off you were. And it's also true that the better the treatment was conducted by mental health professionals, the more effective it was. So mental health interventions, longer and lengthier and multi-level interventions delivered by professionals got the best effects. Next slide, please. So again, this is, I'm sorry, the slide at the top of this cut off, but again, this is where we can intervene in screening for HIV and HIV care treatment. You can click this a bunch of times. I think I've gone over this. The critical first step is screening. And screening and integrating HIV care into medical care provision, thus reducing depression, post-traumatic stress disorder symptoms, substance abuse symptoms. They all improve adherence and can get to undetectable viral load, which is what we're really looking for. And next slide, please. So, how do we do this? Well, it looks different in different regions. There's a spectrum of mental health impairment across regions. There's a spectrum of what we can do in terms of our intervention and in terms of the staff that we have. We need to evaluate things and apply our resources wisely. Next slide, please. And this is the goal of it, because U equals U now. Undetectable viral level equals untransmissible. Can you click this again, please, Nadine? And one more time. These are quotes from people who have achieved undetectable viral levels and been told now that they've achieved undetectable viral loads through adhering to treatment, they're untransmissible to their partners. And this has been verified by the commissioners of health and Health and Human Services, and U equals U is now the standard of treatment. And, it gives people hope again. It gives them hope that they can have relationships, that they're not going to transmit a potentially deadly infection to those we love. It gives people their lives back. And I'll leave you to peruse these quotes on your own, but for people who felt isolated, alone, apart from others, giving them this message, providing them with an undetectable viral load through ongoing care is what we're after. It prevents the spread of transmission. It will end the epidemic if achieved on a high enough level. And to achieve this, we need to treat people's mental health needs. Next slide, please. So the take-home messages here, click please. Mental health problems range from serious distress, serious mental illness, and those people who have serious mental illness are at higher risk than other individuals. Next slide, just keep clicking, please. You can just click them all. Mental health problems contribute to HIV acquisition. We have the necessary screening tools to determine who has mental health needs, and mental health treatment is appropriate and efficacious for these individuals, and it can be done in the context of HIV care and should be integrated into HIV primary care. Next slide, please. And I think that's it for me. I'd just like to acknowledge the AIDS Education and Training Center, of which I'm a part, the HIV Center for Clinical and Behavioral Studies at the New York State Psychiatric Institute and Columbia University, and the New York State Office of Mental Health. And I will stop now and take any comments or questions.
James, thank you so much for that presentation. I wanted to find out what were your thoughts about the EMDR as it relates to trauma and HIV? In terms of its effectiveness, do we have any research around that in this specific population?
I have not seen any research in this population with the effectiveness of the EMDR, but it has been shown to be effective in other populations. I don't know what to make of it, quite frankly. I don't have much experience in it. You would better be asking a clinician with experience in delivering EMDR. I don't really know.
Okay.
I've not seen any literature on it, but then again, I haven't looked. I can look, though, and I will.
Okay.
Do you know anything about them?
I know just like limited information. I've worked with a clinician who used this tool in her practice, or this particular part of therapy in her practice, and she finds it definitely effective with folks who have experiences with trauma.
Right, and post-traumatic stress disorder patients.
Right. So I was just wondering how that relates, or is there any information or research around EMDR? And
again, I know that there's quite a bit of research on EMDR with PTSD patients and reports of success. I know the VA does a lot with it. I've not seen it specifically with the HIV population. Again, I will check the literature on it because it's clearly missing from this presentation. Awesome. So I will look at it. Again, this is a population with a lot of trauma and ongoing trauma. So I could see a usefulness for it. I'm just not aware of anything, but awesome. I will look into it.
Thank you.
You're welcome. Anything else? Well, I'm sorry we did this on a snow day, and I'll be happy to do it again if you need me to with more participants online.
Okay. Can you just explain the greatest differences between mental illness and behavioral health illnesses?
Well, we use the term behavioral health now because mental illness is stigmatizing, and behavioral health seems to be more reimbursable than mental illness. So it's putting the health thing in it rather than the illness. And, it's a less stigmatizing word or phrase for the same disabilities. So there's no difference between behavioral health problems and mental illness problems. It's just more current nomenclature.
Okay. So,
are we done?
I guess we're done.
Okay.
Thank you.
Oh, you're welcome. You're welcome. And like I said, if you want to do it on a non-snow day sometime, I'm happy to do it again.
Okay. Thank you, Jim.
You're welcome.
Awesome. Thank you for your time and have a great day, everyone.
You too.
Thank you.
Thanks.
Bye.
Bye.
So I stopped.